just won a prize, and she's going to fly to Copenhagen to show her work. So,
ignore the redness in my face. Okay. So, okay. Hi, everyone. As Professor Meiri said, my name is Hadar Sadeh. I'm a resident in child and adolescent psychiatry in Soroka. And I will present my study about real-life course and effectiveness of melatonin treatment for sleep disorders in children with ASD that I conducted under the supervision of Professor Gal Meiri and Professor Idan Menashe from the Azrieli National Center for Autism and Neurodevelopment Research, Ben Gurion University, and Soroka Medical Center. So, למה? וזה נוח כזה. ככה, שומעים? אחלה. So we know, לא שומעים פחות טוב? שומעים? סבבה. Okay, so we know that sleep disorders are very common among children with ASD. More than half of the children with ASD will suffer from different kinds of sleep disorders, including prolonged sleep latency, multiple night awakings, shortened total sleep times, and more. We also know that melatonin is considered to be the most effective pharmacological treatment for sleep disorders in these children, with reported improvement in about 80 to 85% of children with ASD that use it. And there are also reports about improvement in daily behavior, even core symptoms, and general functioning under melatonin treatment in those children. Despite all this data that comes from control trials, there is limited data in about real world, real life, and long-term treatment with melatonin. We don't know the real life prevalence of use of melatonin. We don't know who uses. We don't know the real life course of treatment. There are reports that some children will lose the effects during time. We don't know the rates of this phenomenon. We don't know discontinuation rates, reason for discontinuation. And we also don't know the effectiveness in real life and how the comorbidities and the etiology of ASD and all the other psychoactive medication that those children receive influence effectiveness in real life. And so we don't have an accurate picture who will be the children that use, benefit, adhere, and response with melatonin treatment. So these were the goals of our research. First of all, to evaluate the real-life use, effectiveness, and course of treatment of melatonin in children for sleep disorders in children with ASD. And second of all, to try to identify certain characteristics that are associated with use and with response to melatonin treatment. And we believe that answering this question can help clinicians, like me, to give more accurate and personalized fitted treatments for sleep disorders in those children, and also can help us understand the complex connection between sleep, ASD, and melatonin for the future. So what we did, we took all the children from the Azrieli ANCAN database until November 21. They were all diagnosed with ASD. And from them, we took all the children that received a recommendation to use melatonin at some point during the follow-up or reported of using melatonin. And this group included 107 children. And this is the first interesting finding that only 8% of the children in the database were recommended to use melatonin. It's pretty low rates of recommendation of usage. And when we try to understand who are those 107 children, who are the children that were recommended to use melatonin, we compare their demographic and clinical variables to all the other children in the database. And interestingly, we find that the children that were recommended to use melatonin were significantly diagnosed earlier. Their EDA score was significantly higher. The severity of the autism by the DSM-5A and B criteria was higher. Their ABA score was lower. So the overall picture was that the children that were recommended to use melatonin were the more severely impaired children with the more severe autistic symptomatology. which support what is known in literature, that the severity of the sleep disorder is related to the severity of the autism and might stem from each other. And another not surprising finding is that their CSHU, their initial sleep questionnaire, indicated a more severe sleep disorder. So we recommended melatonin to the right children with a more severe sleep disorder. So in the second part of our research, we focused on these 107 children, and we tried to contact their parents, in order to ask them a brief questionnaire that was composed especially for this research, in order to evaluate their experience with treatment. And we excluded children that we have no contact details, children that the parents reported of not using melatonin despite recommendation. And we eventually we included 78 children in our sample that use melatonin for at least a week. All the children use short-release melatonin. It was conducted before the prolonged release melatonin got into the sample thought, and asked the parents of those 78 children a brief questionnaire. So the questionnaire has two parts. The first part contained questions about treatment course. As you can see here, like who recommended, dosages, side effects, continuity, and more. And here are the results of the first part of the questionnaire. You can see that most of the children received the recommendation of melatonin from a psychiatrist. And in about 10 to 11% of cases, it was the parents who initiated treatment. They heard about it from someone. About discontinuation. So in 1/3 of the children, the parents reported that they discontinued treatment permanently when we called them. And the most common reason for discontinuation was lack of effectiveness. But another pretty common reason was natural improvement in child sleep. Another very interesting reason was the phenomenon of the loss of effect during time. That, as I mentioned before, it was reported in the past, this phenomenon. The rates, to date, there are no official rates of this phenomenon, but it's important to know that there are reports that in this kind of phenomenon, sometimes restart medication might restore the effectiveness. So it's important for clinicians to tell those 17% of parents not to stop continuously permanently treatment and try to restart treatment, and the children might benefit again from treatment. Okay, about side effects. So in our study, the treatment duration ranged between 1 week to 88 months. Some of the children in our study used melatonin for more than 7 years. So it's important because you can see that also in long-term follow-up, there were no reports about serious side effects under melatonin treatment. Only 14% of parents reported about side effects. All of the side effects were benign. All of them was rare. Each one happened to 1 or 2 children. And the most common side effects were crying, irritability, emotional lability, and morning drowsiness, which are the common side effects that was reported in clinical trials before. So melatonin in a long-term follow-up is overall safe. Okay, so, and the second part of the questionnaire contained questions about treatment effectiveness in different aspects of sleep, like sleep onset time, night awakings, and total sleep time, and different aspects of behavior and core symptoms of autism, like mood, tantrums, educational functioning, and more. And we asked parents to rate each one of this aspect in a scale of 1 to 5, when the higher rate indicate more good improvement. Interestingly, we found high concordance between parents' rate for effectiveness on night awakings and total sleep times, and effectiveness on mood and tantrums. So this graph demonstrates the rates of the effectiveness on sleep. And you can see that most of the parents, about 86% of the parents, reported that melatonin was effective for the sleep onset time of the child to at least some effect, or at least some improvement in this aspect. The improvement rates in total sleep time was lower. About 53% of parents reported of at least some improvement, and even lower rates for night awakings of about 45%. Of at least some improvement. So the night awakings is not surprising, considering that the children used the short-release melatonin, which helps mostly sleep induction. But the past previous reports indicated that short-release melatonin might also help total sleep times, but the rates in our study was lower than expected. And here you can see the effectiveness of melatonin on the behavior and autistic symptoms of the child. And the scale here you see is not to 100%, it's to 30%. So the rate here was lower. About 28% of parents reported of at least some improvement on educational functioning, and the rates were lower for the other aspects of behavior. Between 5 to 20%. And we believe that this low rate was because parents find it really difficult to isolate the melatonin effect on the child progress and behavior from all the other treatment, paramedical treatment the child received. Okay. So in the last part of our study, what we did is we divided our sample, our 78 children, into two groups, a group of responders vs. a group of non-responders. And this division was made based on adherence, where all the children that were adherent with treatment were defined as responders. But we also included in the responders group the children that discontinued treatment despite effectiveness due to other reasons like child refusal or natural improvement or other reasons. And overall responders group included 61 children, and the non-responders group included 17 children, which demonstrate a response rate of about 78-79%. Okay. In the last part of the study, we compared the different variables between the groups of responders and non-responders. First of all, we compared variables about the treatment course. So interestingly, there was no difference between groups in the age of beginning melatonin. The age of beginning was between 1.5 years to 9.5 years. A very interesting finding is that there was no difference in the final dosage between groups. The final dosage in the two groups was about 4 milligrams of melatonin. And it's important, I believe, for a clinician, for physician to see that the response was not associated with higher doses of melatonin. And this fact is also reported in the past, in previous literature. Another interesting finding was that 14 parents, about 18% of the sample, reported that they use melatonin as an OTC supplementation. They imported it from the US through iHerbs or Amazon, where melatonin is marketed as a dietary supplement. And all those parents were from the responders group. And in the non-responders group, all the parents use melatonin as through an official prescription through the pharmacy. So it is also interesting to see that response was associated with using a non-supervised formulation, and we should think about it. Okay, so the last comparison we made. It's a big table, but I will talk about the important findings, was a comparison between the demographic and clinical variables between those two groups. And we didn't find any statistically significant differences between groups. But interestingly, we found a tendency that the children that responded to melatonin had a higher ADO score, had higher rates of requiring very substantial support by the DSM-5A criteria, and also tended to use more other psychoactive drugs, which might also fit a picture that the children that respond to melatonin are the more severely impaired children with the more severe autistic symptomatology. And I will talk about our thoughts about it in a second. Okay, to conclude, our study demonstrated that melatonin is an effective treatment for sleep disorders in children with ASD, also in real life and long-term follow-up, with effectiveness rates of about 78%. Despite the high effectiveness of this treatment and despite the known high prevalence of sleep disorders in children with autism, the rates of usage is pretty low. There is a low prevalence of usage, which we think might be due to low awareness to the effectiveness of treatment or underdiagnosis of the sleep disorders in those children, and clinicians should remember this. We also found that melatonin use user are the more severely impaired children. And interestingly, we found that melatonin responders have also more severe autistic symptomatology. So we speculate that this last fact might be due to the greater melatonin deficiency that those children with a more severe autistic symptomatology have. So we know from literature that children with autism have low levels of melatonin, and we know there are reports that the level of the deficiency is associated with the severity of the autism, and our studies support this, that the lower functioning autistic children with a low level of melatonin benefits more from fulfilling it exogenically. Okay, that's it. So our study has several limitations. It is questionnaire-based, without objective measurements of sleep. It is retrospective and is prone to recall bias and is a pretty small sample size, but further studies are needed to validate those findings in a larger sample and further explore other clinical and biological variables that can affect melatonin effectiveness in real life. Thank you.